Welcome to the deep dive. Today, we're tackling a really, quite a crucial topic, actually. It's relevant for anyone caring for young infants or even just interested in child health. We're talking about sudden infant death syndrome, or SIDs. You might also know it as cot death.
That's right, cot death, same thing.
And our mission today is basically to pull out the key facts, the essentials from our notes on SIDs. Make it clear, memorable, whether you're, revising for something or just want to understand it better.
Absolutely. And it's vital because, sadly, SIDs remains the most common cause of death in that first year of life, after the initial newborn period.
Oh.
So understanding it is, well, it's critical.
Okay. And you mentioned cot death. Before we go further, what is SIDs? And maybe just as importantly, what isn't it? Because I think there can be confusion.
That's a really key point. SIDs isn't a diagnosis you jump to. It's actually a diagnosis of exclusion. It's the term used when, after a really thorough investigation, and that means everything, autopsy, checking the scene, the medical history, no other cause of death can be found for a sudden, unexpected infant death.
So all other possibilities ruled out first.
Exactly. And it turns out about 80% of those sudden, unexpected deaths in infancy, they do end up being classified as SIDs.
Wow, 80%.
Yeah. And there's growing thinking. Current research points towards potential underlying issues, possibly in the brainstem.
The brainstem. Okay.
Specifically relating to how serotonin works there. It seems there might be abnormalities. This is often called the serotonin brainstem hypothesis.
And serotonin affects breathing, arousal.
Precisely. Breathing, waking up from sleep. Those crucial protective responses. So if something's not quite right there, it could lead to a failure to respond to a dangerous situation during sleep, like low oxygen or too much carbon dioxide.
Okay, that makes sense. So let's nail down the formal definition then. SI is?
The SIS is the unexplained sudden death of an infant under 1 year of age. Typically, it happens during sleep. And the crucial part is unexplained, even after that full investigation we talked about. Autopsy, death scene review, medical history check. Nothing else explains it.
Unexplained, under 1, during sleep, after full investigation.
Got it. So what about the cause, the etiology? You mentioned the serotonin hypothesis, but is that the full picture?
Well, the honest answer is we don't know the exact cause. That's still the reality, and it's one of the hardest things about SIs.
Right.
But the leading theory, the general understanding, is that it's likely multifactorial, a sort of combination of things.
Like different pieces of a puzzle coming together.
Exactly. You might have an infant with some underlying vulnerability, maybe those brainstem abnormalities affecting breathing or arousal control we mentioned. Then you add in certain environmental factors, maybe even a genetic susceptibility playing a role too. It's thought to be this convergence, sometimes called the triple risk model.
Okay, a triple risk.
Yeah.
Vulnerable infant, critical developmental period, and an external stressor. Let's break that down. Those environmental factors seem key, especially the ones we might be able to change. What are the big risk factors there? Yes, the sleep environment is definitely where a lot of the focus is, because we can influence it. The absolute classic risk factor is prone sleeping.
So putting the baby down on their stomach.
Yes, exactly. And there's a simple mnemonic for that. P for prone is P for problem. Easy to remember.
P for prone is P for problem.
Okay. What else in the sleep environment?
Bed sharing. Now, this is a nuanced one, but it definitely increases risk, especially if the parent sharing the bed smokes or has consumed alcohol or drugs.
Right, those specific circumstances are important.
Very. Also, overheating, hyperthermia, and head covering. So avoid piling on too many blankets or clothes, keep the room at a comfortable temperature, and make sure nothing can cover the baby's head.
No hats in bed, things like that.
Definitely no hats indoors for sleep. And finally, soft bedding. Things like duvets, quilts, pillows, cot bumpers, sleep positioners, they're all risks.
So the advice is a firm, flat mattress with just a fitted sheet.
Exactly. Clear, flat, firm, that's the safest.
Okay, that's clear. What about the infant themselves? Are some babies inherently at higher risk? Yes, there are some infant characteristics linked to increased risk. Prematurity is one.
Born too early.
Correct. Also, being male slightly increases the risk. And multiple births, twins, triplets.
Interesting. Why multiples?
It's not entirely clear. Might be related to lower birth weights, often seen in multiples, or other factors associated with multiple pregnancies. Lower socioeconomic status is also consistently linked, sadly. And interestingly, being born in the winter months.
Winter births. Any idea why? Maybe more respiratory infections around? Or indoor heating differences?
Could be factors like that, yes. It's likely multifactorial again. The exact reasons aren't pinned down, but the association is there.
Okay. And then there are maternal factors, things related to the mother.
Yes, maternal smoking during pregnancy is a major one, a really significant risk factor.
During the pregnancy itself, not just after.
Correct. Smoking during pregnancy. Also, alcohol and substance abuse by the mother, particularly if combined with bed sharing, as we mentioned. Younger maternal age, often under 20, is associated with a higher risk. And factors linked to lower socioeconomic status, again, like poverty or perhaps lack of social support.
It seems like socioeconomic factors pop up quite a bit here.
They do, unfortunately. It often reflects access to healthcare, education about safe sleep, and other stressors.
And what about obstetric factors? Things related to the pregnancy or birth itself?
A few things there, too. Late or no antenatal care is a risk factor.
So, not getting checkups during pregnancy.
Yes. Also, low weight gain during pregnancy for the mother and certain placental abnormalities have been linked as well.
Okay, so lots of risk factors, some modifiable, some not. But crucially, you mentioned prone sleeping being a risk. The flip side is placing babies on their back.
Absolutely. Placing babies on their back for every sleep naps, nighttime, everything is probably the single most effective action we've taken to reduce SIDs deaths. Back to sleep. It's a key protective factor.
Right, so we've covered the risks. What about other things that protect against SIDs?
Good question. There are definitely protective factors identified. Breastfeeding is one.
Breastfeeding helps.
Yes, particularly exclusive breastfeeding for at least the first few months, ideally 6. The evidence suggests it lowers the risk.
Okay. Anything else?
Use of a dummy or pacifier at the start of sleep time.
Really? A dummy? How does that work?
The mechanism isn't fully understood. It might help keep the airway open or affect arousal thresholds, maybe. But studies show an association with reduced risk. You could maybe think D for dummy helps defend against SIs.
Okay, another mnemonic. D for dummy helps defend. I'll remember that.
And the other big one is room sharing.
Room sharing. So baby in the same room, but not the same bed.
Exactly that. Having the baby sleep in their own cot or Moses basket in the parents' room for the first 6 months is recommended and is protective. It's distinct from bed sharing, which, as we said, carries risks in certain situations.
Right, crucial distinction. Room sharing good, bed sharing potentially risky. Okay, so we have risks, protective factors. Let's revisit the pathophysiology. What's actually thought to be happening physiologically when SI death occurs? You mentioned the serotonin idea.
Yeah, it's complex and not fully mapped out. But the main ideas revolve around a few core problems. One is impaired arousal responses.
So the baby just doesn't wake up when they should, like if they're not getting enough oxygen.
Essentially, yes.
Yeah.
A failure of those protective reflexes that should kick in. There's also likely abnormal regulation of breathing and heart rate involved. That serotonin hypothesis fits here, suggesting maybe some infants have subtle differences in how their brainstem controls these vital functions, especially during sleep transitions.
So it's like their internal systems are just a bit more vulnerable.
That seems to be the case. And when these internal vulnerabilities encounter an external stressor, maybe a minor illness, maybe overheating, maybe rebreathing exhaled air, if face down on soft bedding, that combination proves fatal. That's the thinking behind the triple risk model we touched on earlier.
Vulnerable baby, critical time, external stress. It sounds so precarious. So if a baby dies suddenly, how do clinicians figure out if it was SIDs or something else entirely? The differential diagnosis must be quite broad.
It is, and it's absolutely vital to rule out other causes. That investigation process is key. Potential differentials include accidental suffocation, perhaps from unsafe bedding or co-sleeping situations.
Okay.
Infections need to be ruled out, things like sepsis or meningitis. Certain metabolic disorders, inborn errors of metabolism can present this way.
So underlying conditions.
Yes, and cardiac abnormalities like certain heart rhythm problems need consideration. And sadly, non-accidental injury or child abuse must also be carefully considered and excluded.
A very difficult but necessary consideration.
Absolutely necessary for the child's sake and for understanding what happened.
Okay. Let's look at the numbers. Epidemiology. How common is SADs, particularly here in the UK? Has it changed over time?
Well, in the UK, it's still considered a leading cause of death for infants between 1 month and 1 year old. But the really positive story is the dramatic decrease in incidence over the past few decades.
That's mainly due to the safe sleep campaigns, like Back to Sleep.
Overwhelmingly, yes. Those public health campaigns have had a massive impact. Current rates are around a 0.3 to 0.4 deaths per 1,000 live births.
And that's down from
Much higher levels previously.
Hmm.
Just to give you an idea of the progress, the mortality rate more than halved between 2004 and 2019. In 2019, it was down to 0.16 per 1,000 live births.
That's incredible progress.
It really is.
Yeah.
But even with that drop, in 2019, SIDs still accounted for a significant chunk, about 59% of all unexplained infant deaths. So it hasn't gone away.
Still the most common reason when a death is unexplained.
Correct. We also still see that higher risk for mothers under 20. And just for comparison, the U.S. rate in 2017 was about 35.4 per 100,000 live births. Different ways of reporting, but shows it's a global issue where safe sleep messaging is key.
So, much rarer, but still a tragic reality. How does it typically present clinically? Are there warning signs parents can look out for?
This is one of the most heartbreaking aspects. There are usually no warning signs, typically no specific signs or symptoms beforehand. The presentation is defined by its suddenness and unexpectedness occurring during a sleep period. The infant, often seemingly perfectly healthy before sleeping, is simply found unresponsive. And tragically, they cannot be revived.
That's devastating. Just found unresponsive.
Yes, usually affects apparently healthy infants.
So in that terrible situation, a suspected SIG's death, what investigations happen then? It must be an incredibly sensitive process.
Extremely sensitive. And a standardized, thorough investigation is crucial. Firstly, a full postmortem examination and autopsy is essential.
To look for any hidden cause?
Exactly. To identify, rule out infection, metabolic disorders, congenital abnormalities, injury, suffocation, anything that could provide an explanation. Secondly, a careful examination of the death scene.
What does that involve?
Looking at where the baby was sleeping, the bedding, room temperature, any potential hazards. It helps piece together the circumstances. Then, a detailed review of the infant's and family's medical history. And finally, specific laboratory tests might be done, again looking for infection, metabolic issues, or toxicological factors.
Our notes also mention some really specific points for healthcare professionals attending such a scene. Things to do and maybe things not to do.
Yes, these are so important for handling the situation with care and compassion alongside the investigation. You'd need to carefully note the infant's position when found, their clothing, any secretions around the mouth or nose.
Details for the investigation.
Precisely. You also have to explain, gently, the legal necessity of reporting the death to the coroner or the procurator fiscal in Scotland. But paramount is supporting the family.
How is that best done in those initial moments?
Offering immediate support, perhaps arranging for another family member or friend to be there, ensuring someone stays with the parents. Reporting the death promptly to their GP and health visitor is vital, so ongoing support can be coordinated. Expressing genuine sympathy, avoiding jargon, and providing contact details for support organizations, like the Lullaby Trust in the UK, which offers specialist bereavement support.
And the things to avoid.
Crucially, don't press the parents to recount the events over and over, unless they want to talk. Avoid cliches or platitudes, however well-intentioned. And never make comparisons to other cases. Every family's grief is unique and profound.
That sounds like incredibly difficult but vital guidance. What about the longer-term management, especially in the UK, after the initial investigation?
The main focus shifts entirely to support and counseling for the bereaved family. It's about providing access to psychological support, grief counseling, connecting them with peer support groups if they wish. There's no treatment for SID itself, obviously.
And reinforcing prevention messages.
Yes. Alongside supporting the bereaved family, public health efforts continue to focus on promoting safe sleep practices within the wider community, reinforcing all those messages. Back to sleep, firm, flat sleep surface, no loose bedding, avoid smoke exposure, comfortable room temperature. It's about preventing future tragedies.
Is there any specific follow-up for siblings?
Yes. It's generally recommended that any surviving siblings, especially younger ones, or subsequent children born to the family, are reviewed. This might involve screening for potential underlying conditions like sepsis, if there was any recent illness, or considering investigations for rare inborn errors of metabolism, just to be cautious. Though it's important to stress the recurrence risk is low.
Okay. Which leads us to prognosis. It feels like a difficult word to use here.
It is. For the infant, the prognosis is tragically the death itself. That's the stark reality. But for the family, while the risk of SIDS happening again in another child is low, that's often a major anxiety.
I can imagine.
So reassurance on that point is important. However, the long-term psychological impact on parents, on siblings, on the whole family, it can be immense and last for years. Coping requires significant ongoing support.
And are there complications beyond the death itself?
Well, SIDs is the ultimate tragic complication, isn't it? The main complications are the profound and enduring psychological and emotional consequences for the family members left behind.
Yeah.
Grief, anxiety, depression, PTSD. These are common and require dedicated support, often professional grief counseling.
It really underscores the importance of that family support aspect.
Absolutely, it's critical.
Okay, so let's try and summarize this deep dive. SIDs is, it's this unexplained sudden death in an infant under one, usually during sleep. The exact cause isn't known, likely multifactorial.
Involving vulnerability, a critical period, and external stressors.
Right. And while we don't know the exact cause, understanding the risk factors, especially the modifiable ones like sleep position and environment and the protective factors, is absolutely key.
Definitely. Remember, P for prone is P for problem.
And D for dummy might help defend against SIs.
Exactly. Implementing safe sleep practices based on the evidence is truly the cornerstone of prevention. It's made a huge difference.
It really has. It leaves you thinking, though. Considering SIDs has so many potential contributing factors, what do you think is the most challenging part of preventing it now? And maybe, how can we get even better at supporting families to actually use the safe sleep guidelines consistently?
That's a really tough question, isn't it? Getting the message across consistently to everyone, overcoming barriers. It's complex.
Something for all of us to ponder. If you want to solidify your understanding or revise this further, do check out the resources over at pastthemsra.com and freemsra.com. Thanks for joining us for this deep dive today.